Welcome to Bruce Hurwitz Presents Meet the Experts. I'm your host, Bruce Hurwitz of Hurwitz Strategic Staffing. You can find us on the web at hsstaffing.com. I hope you'll consider us for all your staffing, career counseling, and professional writing needs. Momentarily, I will be joined by Jason Povio for a discussion on the rise of telemedicine. Meet the Experts is sponsored by P&K CPAs. P&K is a full-service accounting firm. They provide accounting and consulting services to businesses ranging from startups to small and mid-cap companies to nonprofits, as well as high-net-worth individuals. Contact them today for a free consultation at info@pk-cpas.com or call them at 973-882-8810. They will be happy to be of service. Jason, welcome to the program.
Thank you. Thank you for having me.
Why don't you take a moment or two and introduce yourself to our viewers?
Sure. My name is Jason Povio. I'm the Chief Executive Officer here at Eagle Telemedicine. I've had the pleasure of kind of steering the ship over the operations and strategic direction of this organization for the better part of about 5 years now. Prior to joining Eagle, I started my healthcare journey on the health system hospital side of things, and really have an appreciation for the challenges that many of the hospitals and health systems kind of face today. I was charged with at one point developing telemedicine virtual strategies for a very large catchment area across multiple specialties. So I have a real acute awareness to the challenges in rural communities to create access to care. And so that sort of translated really well for me as I stepped into this role. And just, I'm having a lot of fun really helping this organization create pathways to meaningful access for communities across the country. So look forward to the conversation today and sharing a little bit about what we're doing.
Is telemedicine just simply talking to a nurse or a doctor over the phone?
No, it's quite a bit more than that, and it's a really good question. I always explain it to folks that the bigger umbrella is telehealth, and within telehealth, there's a lot of different um, elements to that, a lot of different modalities. There's remote patient monitoring. So anybody that wears like a Fitbit or a, Apple Watch, anything that's a remote device that could be monitoring vitals or any other types of things that could be connected to a system and reported back to a primary care physician or a specialist. That's a form of telehealth. That's virtual care, so to speak. You have virtual nursing. You have virtual patient sitters, patient monitoring. Where we fit in, and the telemedicine spectrum really is the virtual delivery of specialty care services by a physician. And so that is the direct connection between a patient and a physician through virtual technology. And that interaction that takes place, that care plan that happens through that virtual presence with high quality video, audio, and physicians having direct access to a patient's medical record so that they can see diagnostic results, images, and things of that such to progress the plan of care.
Now, this only applies to me because there was a conversation between me and my cardiologist, so I don't want somebody who knows what I'm talking about to draw any conclusions that are relevant for them. But I'm at my cardiologist, and there's a poster on the wall saying that their medical group offers this electronic service. That's not what it's called.
Okay.
That monitoring that will let you know if there's something with your blood pressure, your heart rhythm, whatever.
Mm-hmm.
And I have a very good relationship with him. Next time I see him, I will say to him, "Doctor, the plan you set up for me was great. I no longer exercise. I only eat fried and salty food. And instead of taking medication, I have a glass of whiskey every night. And he will say, well done. All right. The nurses might not get it, but he'll get it. So I asked him if this would be good for me, 24-hour monitoring, what have you. And he said, no, it'll drive you crazy.
Yeah.
When is too much too much?
It's a great question. I think there's a lot of factors that probably need to go in or that go into that decision. It's, are you being treated for an acute episode that maybe took place and you're healthy otherwise. You don't have maybe too many comorbid conditions, and just things happen, right? And that's why hospitals exist, because when an acute thing happens, I need to go make sure I'm not dying and move on. But if you're an individual that has multiple comorbidities, you have a chronic, disease, diabetic, AFib. I mean, just the things that are chronic and persist. Those are the types of factors that could go into a decision of, is there benefit for me and my care plan? Or can I make enough changes based on the monitoring that can be provided to avoid acute episodes that may land me in the hospital? I mean, diabetes is, kind of the precursor to monitoring, right? Glucose monitoring, blood pricks, all. Now they got constant monitoring. You get the phone. I mean, there's a lot of value in knowing where your blood sugar is at any point in time to make a course correction to avoid a downward spiral. And so those are the types of things that you want to take into consideration to say, hey, am I looking, or is it good for me to subject myself to the constant pinging and alerts of potential diagnostics? But if in reality you can't make changes in a more real-time sense, it's probably overkill, and it's a little too much. A lot of the disease states are more like a trended situation. How is your blood pressure trending over time? Or I just had a physical recently, and PSA is a big one, right? And the thought now is it's about the change that takes place over the course of time rather than the actual score. And so if you see changes, that's more indicative of maybe something is going on than the actual score itself. And so if I had something that was monitoring my PSA every day, for what reason? So it's I'm not going to be able to do much with that. And so I think that's when enough is enough, or it becomes enough. It can be a utilitarian tool, but it's got to be sort of fit for purpose, if that makes sense.
One thing, which it could just be the camera in my eyes, but if people are noticing that it is getting darker behind you, we are conducting this interview as the solar eclipse takes place.
That's correct.
If for any reason this should go out, then the world has been destroyed, and so much for telemedicine. What now? You have a cold, you call the doctor, you speak to a nurse practitioner probably.
Yep.
You say, I got a cold, I feel terrible, I've got a fever of this, and I ache all over. And she says, take 2 aspirin, drink plenty of fluid, and call me in the morning.
Yep.
Fine. You have a pain in your stomach, in your side, and it's been bothering you for some time. Well, the doctor can't touch you. You
Correct.
can touch you. You can say, yeah, it hurts. Well, press harder. Does it hurt more? Yeah, it hurts more. Okay, go to the emergency room. Appendicitis,
Yep.
for example. you say, I've got a rash
Mhm.
or I've got a wound, and you use your phone and you show them the rash or the wound. Is there a different type of expertise? I'll tell you why I'm asking the question.
Okay.
When dentists first had to use gloves, I was having my first root canal. It's supposed to have been 20 years ago in the AIDS era.
Okay.
And dentists were required by, I don't know, by law, but by their the dental association to wear gloves. And the doctor was feeling around my mouth. And I said to him, as far as I'm concerned, you can take the gloves off. I trust you. You can trust me. There's no blood disease on my side. I'm sure there's none on yours. And he said to me, Bruce, thank you. I can't do that. It's against the rules. Plus, I have to learn how to feel through the
Gloves.
latex,
Yep.
which made sense. Do nurses, doctors, medical practitioners have to learn how to view a wound through a phone? Because it might look different.
To some extent, yes. However, the technology has always been, in the top quadrant, the old Gardner Magic Quadrant kind of stuff. But it's the optical and digital zoom factors on these things would probably amaze many people. I've rolled these carts into boardrooms with board members and have had a physician just randomly pick a board member and zoom in on a pupil from 15 feet away, and to be able to watch like pupillary response. It's just, and it's amazing. And everyone in the room, you always get kind of that shock and awe kind of reaction. And so the technology really facilitates and really enables a quality exam. But you raised a good point. I mean, and so I'll take example, inpatient medicine. So you got a patient that's actually in the hospital bed, and you have a nurse in the room, but I've got a cart at the end of the bed and a physician on a screen, right? The physician's not physically in the room, and the physician would traditionally or normally palpate the belly to get a feeling of the resistance and watch for the reaction from the patient, as part of a physical examination. Well, healthcare has always been a team sport. Telemedicine sort of exacerbate and says, hey, it has to be a team sport. The only person in the room right now that can do that is the nurse. And the nurse is trained. It helps to maintain they work at the top of their license, but they are trained, and it's in their core competency to palpate the belly and put their hands on it. And the physician on screen can watch and can observe the reaction, tell the nurse here or there, and a good quality exam still takes place. And so there are definitely nuances across specialties and across care settings that have to be adopted so that a good quality exam can take place. And in many cases, that means we have to operate far more like a team. I mean, we say we do, but this forces us to operate like that. And then we'll talk about the rash of the wound. Well, if I'm on screen as a physician and I'm looking at the patient in the bed, I certainly am not aware of, I can't roll the patient over. So I'm gonna need the nurse to say, hey, there's actually a wound here on the backside. I want you to take a look at. So they have to help kind of shift and move the patient. And we can then zoom in and take a look at it. Another element is, if we're looking at it live, but then there's always the element of store and forward. And you'd be surprised, maybe you wouldn't be, the quality of snapping a picture these days and then sending that, either through the electronic record or whatever, and the physician being able to look at it. It's called store and forward. You're just looking at images. But all of these different avenues of technology are at our disposal to ensure that we're able to deliver a quality examination. But to your point, you do have to learn how to do things a little bit different. You have to learn how to, one of the interesting things you got to learn to do differently is just bedside manner. It's called bedside manner. We call it website manner. But, how do you interact with a patient so that they get the sense that you're there and not, because like you and I talking now, I could kind of just look over here and you can see me looking over here and you may get the sense that I'm not maybe paying attention. And if you're virtual, it's kind of easy for our eyes to wander a little bit versus if you're in the room looking at the patient. And so we teach our physicians to maintain kind of eye contact with the camera, which gives you the best perception that you're keeping eyes on the patient and maintaining eye contact through conversation. So just different things like that. So there's definitely a bit of a learning curve for physicians in delivering telemedicine care.
You just answered my next question, because one of the things that's important for me is the physical contact, the tactile.
Yep.
With physician, dentist. When I make a stupid statement like the one I said I will make to my cardiologist, or to my dentist when at the end of the examination he says, are you brushing and flossing? I say, yes, doctor. I brush my teeth religiously once a week and floss once a month, whether I need to or not. And he'll pat my shoulder and say, see you in 6 months. All right.
Yep.
Now, the patting of the shoulder tells me, A, he knows I'm kidding. B, everything's okay. And we're on a friendly basis. You can't have that with a phone.
You can't. And there's nothing to get around that, at least today. And who's to say what technology does in 15 years from now? But that whole example we shared about touching the belly, maybe 15 years from now, they'll have the carts and the robots that actually can do that and send the sensation back somehow. I don't know, right? Nothing seems impossible these days, but you're right. And we're not able to get around that. And so that's where other elements, you lose a sense, right? We have senses and you lose that sense, the sense of touch. So you need to have a heightened awareness to the remainder of the senses that you have and can use, and use those to, exploit's the wrong word, but I mean, leverage those in a way that make up for the lack of that sense that you don't have. And in addition to that, kind of repeating what I said, but it's important to establish the workflows and norms with the team. So the nurse is still there to pat on the back, if you will. It's not the physician, but it could be the nurse.
Sure.
Our physicians, we manage a lot of ICUs. Okay. If you're in the ICU, you're in a bad way more times than not. Okay.
Yeah.
Prognosis isn't great. Otherwise you wouldn't be in the ICU. And so there are patient deaths, right? It's unfortunate. It's a part of life, but it happens. And our physician's going to have a conversation with the patient or the family, right? Our physician isn't going to hop on a plane at 1 a.m. after pronouncing death to meet with the family at 3 a.m. I mean, logistics don't allow for that, but they still got to have that conversation. How do you ensure you're empathetic? How do you relay that message? You're over a screen talking with family members who might be at the bedside or maybe in a consultation room. We don't have those conversations without somebody physically present is how. Somebody else from the care team has to be physically present with us, with the patient's family, to have that conversation, because we believe it's important to ensure that that connection can be made. The nurse can hold the mother, father's, son's, daughter's hand, to provide a sense of empathy while the physician is conveying the message. So so there, again, that goes back to you have to find what the norms are, define them, and then implement them to ensure that good quality care is taking place, and nobody feels like something is missing. And we've done that really well. I mean, we've had stories of, and this may sound crazy, but we've had stories of um, families getting up and actually hugging the robot, hugging the cart like a virtual. I mean, so there is a way to do this to where on the other side it's received in a way that is meaningful and impactful to patients and families.
It's interesting when you mentioned senses. So I remembered all five. And the doctor will still have their own sight and sound.
Yep.
It's the nurse who's going to provide the touch, smell, and taste. Although I can't think of any time that the doctor has ever worked on me and taste was a factor.
There's some old stuff around diabetes and tasting, and I did it
don't know.
long ago. Long ago.
They no one's come to me for bloodletting or leeches.
Yeah.
Two more questions I want to get to.
Sure.
There are commercials for erectile dysfunction medication, and no, that is not something which I have experienced, just to be on this, to make sure that people don't think that I'm exploiting this for personal reasons. Now, it says on the commercials that you simply go to the app, ask a few questions, and a physician will issue a prescription, and then the drugs will be, the medication will be sent. Now, this is real medication.
Yes.
This isn't con artists who call you from US Pharmacy.
That's correct.
Is that part of telemedicine?
It is.
And how do you know that it's legit?
As a patient?
Yeah, as the physician, I could call up, I know what answers to give. I give those answers. You give me a prescription.
So that is correct. There's no denying that can take place. Many of it's called direct to consumer. So, these are, they may be connected with payers like big Aetna, Blue Cross, and I'm not.
Whatever.
Yeah. And they're providing care to their patient population, or it could be more of a consumer-driven, direct-to-consumer service out there that is providing those types of services for particular afflictions, we'll call it. And I always tell patients, and I get asked this quite a bit, but do your homework, do some research. Make sure that the service that you're engaging in or seeking for is legitimate. But the companies that are providing this service, many of them have safeguards. They have a lot of safeguards in place to validate identity, validate different pieces of information to ensure that they are mitigating that risk. But it's an old adage, right? I mean, anything can be leveraged for bad.
What I was getting at is, what are the cases of abuse, not on the side of the healthcare providers, but on the side of so-called patients who are just looking for drugs?
Well, that is the case, and that does happen, and that's why many of these organizations have put in and have the place safeguards in place. They may have things like care navigators in place that becomes a stopgap between the application and answers and actually getting to a physician and a script. And many of these organizations have decision tree algorithms that help define whether or not this could be a truly asynchronous type of event, meaning I don't need to see or talk to the patient. All of this checks out. Here's your prescription, or something is flagged. There needs to be a conversation, and then maybe even an initial consultation with the physician, which would be abbreviated, and then an order for the script. Nothing is perfect. And so things do get through, and bad actors do what they do. But yeah, it's certainly something that these organizations face and have to build in workflows and safeguards to avoid. So
And coughing be dealt with. It would appear to me that the perfect care over telemedicine or using telemedicine would be mental health.
Yep. It's a great use case. I mean, and I know that there's a lot of activity from a legislative perspective to help facilitate easier pathways to ensure behavioral health services can be delivered virtually. The system isn't perfect, and it has a lot of barriers, administrative barriers, like state licensing, for example, having to be licensed in both the state that you are currently practicing from and the state that the physician resides in. And that presents it's a cost burden to the physician and or the organization that employs the physician. And it's a timeline. It's a time barrier. I mean, it takes time to license. Many states are average around 4 to 6 months. So that's 4 to 6 months. I can't be delivering care while I'm applying for my state license, submitting all the right paperwork, going before the state board, and then being granted my state licensure. I may have to take a jurisprudence exam. I mean, all these different, and no state's the same. Right. And I got to pay my fee. I got to pay my application fee and this, that, and the other. And then if you want to start talking controlled substances, which you do have in behavioral health, now there's some DEA components involved. And the DEA has its own set of rules and guidance. And so there's a lot of legislation right now that's out there, that's being pushed, advocated, lobbied for, that is trying to streamline those things that help to facilitate delivering the care faster and easier. But behavioral health in and of itself really does lend itself quite well to telemedicine. Obviously, there's far less of a physical examination component to the visit. And so the need for some of the what's called periphery. I don't need a dermoscope. I don't need a stethoscope. So your obviously your capital cost expense and need for some of the technology doesn't exist. I just need really high quality audio, video to be able to facilitate that exam, and a good means by which to monitor your progression to a care plan, and whether that's with medication or some other types of therapies that are being prescribed or put in place by your psychiatrist. So, and then within behavioral health itself, there's more levels of caregiver opportunity to with licensed clinical social workers, psychologists, psychiatrists, nurse practitioners, and the like, that can do participate in the delivery of care. So that and stroke are the two kind of biggest use cases for telemedicine.
Jason, I want to share your contact information and ask you one final question.
You bet.
Is there anything I didn't ask you which you wish I had asked you? And if I had asked you, what would you have said?
Um, I get asked a lot, physician adoption. Like what is, the physician's adoption to telemedicine? And that obviously had a huge step change through the pandemic, right? I mean, it was kind of a forced adoption, and everyone's like, telemedicine's great, but the adoption by physicians has continued to rise year over year for a variety of reasons. One, the technology has gotten um, so much better to the place where physicians feel more supported in the delivery of care, easier access to, like I said, diagnostics, the ability to monitor or check in on patients, to ensure that the therapies and the plan of care are progressing. And it is creating an opportunity for physicians to kind of control the narrative a little bit more on their lifestyle. And so we go through interesting seasons of recruiting with physicians around new mothers, new graduates, more seasoned physicians wanting to have less kind of in-clinic burden, but still want to deliver quick care to patients. And telemedicine really provides a lot of different avenues for physicians to kind of extend the life of their practice. We've got a math problem that gets talked about a lot with shortage of physicians, and there's no one solution out there to that. Telemedicine is just kind of a solution of many that help to distribute physicians in sort of maldistributed areas, if you will, and allow physicians to kind of practice longer on their own terms. And so I'd say that would be one question, is just what do physicians think about this, and that would be the answer.
Well, Jason, I thank you, and I will not object if you have one of your physicians send me a bottle of codeine. Just kidding. Don't want anybody to think differently. You've provided a great deal of information on a very important topic. And on behalf of myself and our viewers, I thank you profusely.
You're welcome. Thank you very much.
I'm Bruce Hurwitz. Thank you for watching. And as always, please stay focused on success.